Good. I'm Jeremy Nibbs, the publisher of Medical Republic and Wild Health, and with us today we have an expert panel to discuss our topic. They are Kylie Ward, the CEO of the Australian College of Nursing, Georgina Willits, co-chair of the Occupational Violence Committee within the ACN Nurses and Violence Task Force, David Williams, country manager for ASCOM, and Jackson Nilberg, who is a registered nurse and founder of the Nurse Break. Before I start, a bit of housekeeping. We will stop for audience questions. If you want to ask questions, you've got a Q&A button at your bottom, and we'll take the good questions where we can, and where we miss them, we'll get them to you afterwards. The webinar is recorded, so you can come back to it afterwards as well. A quick but important note of thanks to ASCOM, whose sponsorship of this webinar series has made it possible. Okay. Statistics on violence in healthcare workplace settings prior to COVID intervening indicate that the problem is rapidly escalating, but the data is poor and the reasons aren't entirely clear why that data is poor. That data is still poor on such an important topic, and funding for change still relatively low is probably some indication that the issue is still being treated by some policymakers as a sort of, it goes with the profession type of problem. Without more support from government and policy makers, some of the issues that exist around violence in the healthcare workplace are going to be difficult to fix. But within the realms of a hospital, a medical practice, an aged care facility, and other hotspot locations, there are some things that staff and their administrators can do and are doing now to move the dial on the problem. In this webinar, we're going to look at what technology is emerging that can help. We're going to look at the greater problem surrounding it, but we're going to look at what specifically what technologies can help in the middle of it, where it fits in the context of a very big and complex problem. We'll start by trying to get a summary of the bigger problem and all the things that are being done to address it. And unfortunately, Georgina, that's going to be your question. So to put you on the spot, do you think that you can set the scene here by outlining all the things you see that are in play to help you address this problem? Things like education, environmental factors, organisational policy versus regulator policy, right down to at the coalface what technology you have and how it's being managed to support it, and also where the data is and why you think the data is there. That's a big question, I apologise, but that's your opening question.
Yeah, I think that is a huge question, and thank you for that, Jeremy. I think if it all boils down to it, it's a social issue that this is about. So it needs to be multi-pronged, and it needs to be addressed in a huge way. So the Australian College of Nursing have started this journey. So it's a beginning and not an end, for absolutely. And I think that, our members have overwhelmingly identified just how important this issue of violence and nurses is for us in our workplace. We are the biggest healthcare profession. We are predominantly female. It does have a gender significance to it. It does need to be tackled from government, from community, from social, from education. And there's been a lot of work done around this, but the implementation hasn't always happened. It hasn't always been done, on a national level. So data is not always appropriately collected. It's very complex. So the ACN has put together, under Kylie's leadership, the task force, and I co-chair one of the task forces, one of the areas, and I'm co-chairing the occupational violence. But there's some other areas that we identify in nursing too that are really important, and that's nurses who experience domestic violence, nurses who care for people experiencing domestic violence, and also nurses in child protection. So it's not just occupational violence. For us in our workplaces, it really encompasses everything that we do. So certainly, there needs to be some educational focus. We can always talk about that. And there's been a lot of work around developing that. I think that always limits things. We can do as many educational packages as you want. It's the implementation of that. And it's the implementation at many levels of that needs to be done. So, it's hugely complex. And I think for each of these committees that we're on, we've got key priorities that we've identified. So it's like we're taking some small bites at the apple as we progress through this. So I think probably, Kylie, you would have a lot more that you would like to add if you want to come in now and say something, because I think that probably is a good idea as the CEO of ACN.
You're on mute, Jeremy.
Kylie, the stats are horrific even prior to COVID. And when I did the research around it, I was amazed that such an obvious problem that is getting so much obviously worse, and that might be more recognition of the problem, I don't know, seems to be not coordinated between states and at a federal level. And there does seem to be this real thing of, yeah, well, you know, what do you do? It's a part of the profession. And I'm wondering, because you're in Canberra, you see what's happening, and you can read the tone of what's going on. Why is that? Why are we not making significant progress, particularly given the last year and a half of politics in Canberra?
Thank you, Jeremy. You know, good question. Well, whilst we live in a society or a world that tolerates violence against women, the nursing profession is going to experience occupational violence. I think for many years, nurses, you know, myself included, just took a lot of it as part of our job, people not coping. We choose these professions and this industry to give and to care. And sometimes when those boundaries and borders are blurred, you know, you take it on yourself rather than thinking, I'm worth not tolerating this. And so I think that there's been a history of tolerance that has to stop. I think that what the nursing profession experiences is systemic of what society experiences. And I think, as Georgina mentioned, because we're 90% female dominated, we're going to experience that in certain ways. And that transference, I mean, I think it's fair to say that nurses will have experienced people, patients, relatives speaking to us in a certain way. And then when our fellow colleague, a doctor, walks in the room, they get spoken to differently. So I think there's some things that we have to do at a fundamental level to influence society. The reality is today, nurses experience more occupational violence than police officers and prison guards. And so why is it okay to continue that? I want to see governments, employers, creating psychologically safe workplaces, having a zero tolerance approach to any occupational violence. Hopefully we can push it professionally and improve society. But then also there's a massive underreporting. And so what we need is to then make sure that we are gathering the amount of violence, whether verbal abuse, physical abuse, grabbing, you know, all the different elements to that. We're talking today about occupational violence. There's also the sexual assault and sexual harassment component that's also coupled with this that nurses have faced all throughout their careers as well.
So I gather massive underreporting might mean that technology might be able to help, which we can get to. I was just going to come back. You know, it's a very well-known statistic that in the workplace, women won't be as nearly as pushy for a promotion as a man, even though they might be far more qualified. I was talking to a nurse in a regional base hospital, and she works in mental health, and I don't talk to a lot of nurses. And when I heard her stories, and she was really literally like, oh, you know, that's okay. This is just how you handle it. I really got a sense of there's a whole realm of nursing that people don't see because women manage it the way women manage it, and males, and I'm male, don't really have a perception of it. And I wonder how you get that problem. I wonder how you get that problem into a Canberra sphere for attention. Well, that's, yeah, if you want to grab that question just quickly, Kylie, it's a hard one, I think.
I think it's really important to bring it out to the surface. It has been in the shadows. I think we are the most trusted and ethical profession. Why is that? I think it's because we work so intimately with the people that we care for. There's such vulnerability around what we do. So nurses don't beat our chests. We don't do this for the financial gain or the accolades. And we have the sacredness of that privacy and that confidentiality. And people know they can trust us for that. So we don't show to the world all those little things that make a difference to the experience of providing nursing care. But that also comes at a cost that we forget to say what we need to do where our experience isn't honoured. And so I think that the best thing that you're doing, Jeremy, and for something like this is let's bring it to the surface. Let's have the conversation. There may be a nurse or an employee or someone working in this industry who even having this conversation will raise the awareness that it's actually okay to talk about and it's not okay to tolerate. The other thing that every cause needs, as much as violence against nurses or violence against women, is great men and our colleagues. This isn't a women's issue. This isn't a nursing issue. This is the likes of you, Jeremy, and we've got Jackson as a champion nurse. We all need to step up and say, not enough. It's not good enough for nurses, daughters, sisters, aunties, uncles. It's got to stop. So I think getting it on the table, having the discussion, and then we get heard and then we find solutions.
Yep. Good segue to our nurse who happens to be a male, but someone who's done something really interesting in that is a full-time nurse, but has taken on himself to have a blog, which is a fantastic blog, and then done a video series. And I think sort of you can describe it, Jackson, but sort of fell into the idea that, fell into the problem and then did a fascinating series of sort of very cold-faced videos, which enlightened a whole lot of people and got a lot of press. Jackson, you're sort of our cold-faced guinea pig. You aren't at the policy level, but you're starting to become some sort of influencer, I think, in a sense. What's your take at this point in time on the situation, given where you are? I know you're not a policy person and you're not high up. You're at the coalface. You've come in, relatively quickly out of training, I think, and you've just seen something, and you've done something quite interesting because you've exposed it, like Kylie said, at a level that's very accessible to, I think, a lot of young nurses.
Yeah, thank you, Jeremy, for having me, and it's glad to be here. Never been called a guinea pig, but I'll take it. I used to have guinea pigs and they're very cute, so I'll take that as a compliment. So yeah, you're not wrong. I've been a nurse for, sometimes I say 7 seconds, but it's been about 3.5 years. And in that time, across a range of different sort of areas I've been working in, I've seen some intense violence, and I've seen people injured. I've seen people physically and psychologically and mentally injured. That's the consequence of violence. But I just wanted to sort of pause for a second and go back to like the causes of violence. Before nursing, I did a criminology degree, so I find causes and the reason why people commit different types of human behavior interesting. I guess I would start with the caveat that, and it sounds bad, but we will never be able to completely stop violence in healthcare, regardless of the technological or mitigation strategy that you use. There will always be an element of violence. And the reason for that is because, as Georgina said, it is a social issue and there's always been violence throughout history. So the pessimism in me says that we will never be able to completely stop violence in nursing. There are so many causes of violence. There's people who are clinically confused, the clinical causes of violence and mental health issues, and we can't stop those completely. We can obviously mitigate the effects of those. And I think that's where what ASCOM can play into a bit with the, duress phones and getting quick responses. That's sort of the reactive response to this violence. And then we have things that we can stop, and that's the drug and the alcohol and the different types of mental health presentations, the frustration, the unmet needs. There's so many types of causes of violence. So if we can sort of differentiate between what we're trying to tackle, that's important. There's some really good research out of some great nursing professors from Monash Uni a few years ago, and they highlight that there's so many causes beyond what I've just mentioned to violence, and that includes, as Kylie said, so nursing profession is primarily female, like 9, 10, 11% of us are male. And there are, long-term reasons behind why a female population might be susceptible to more violence, right? There are cultural and organizational reasons, and this acceptance of violence, as you sort of mentioned. So there's organizational, there's gender-related reasons, there's so many other types of reasons. There's so many reasons that it's hard to put a treatment to it and say it'll fix everything, because there's so many types of violences, causes of violence.
That's partly why. So one thing I was going to ask you is, the stats say it's getting worse. I'm not sure if it's reporting getting better or the stats getting worse. But if the stats are getting worse, why do you think the problem's getting worse?
So back in the criminology days, when you look at police statistics and you go, well, there's more sexual assault against women, it must be because there's more reporting. That's definitely an element of it. There probably is more reporting.
Yeah.
But it doesn't mean that there's less violence or that it's not increasing. I would say violence, from my experience and just from anecdotal experiences speaking to people through this process I've been on, violence has been rapidly getting worse over the years. You speak to police sergeants and they will anecdotally say to you, when I started, the violence was not like this. You speak to directors of nursing and they'll say, we did not have this amount of violence, physical or verbal, to nursing staff 20 years ago. And I think, why are the statistics getting worse? Well, I would pause and say, where are the statistics? I mean, where is the national standardized database that every health service, aged care, private, public, regional, rural, like every health service puts their standardized data set into a national database and you can look at the data? Because I don't know if it actually exists. And I bet you if you actually did that, you would realize it's worse than what we're saying, and then they would realize that they need to do much more about it. So it might scare a few policymakers and they might not want to do it. But there is a lot of issues in this sort of, and I've learned a lot from the video series that I did with Daniel from the archive, and getting emails from people, nurses who told me it got a lot worse than I thought. Nurses who were emailing me and telling me they've been raped, stabbed, chased out of hospitals when they've left their shifts, stalked. We even reported in the video, if you watch the video, Helen talks about having to take a restraining order out on someone. So like the violence there's so many types of violence and it can go to so many extremes. So, and it can result in people dying, and it happens every year. I'd say there's a nurse who dies, or more than one.
Wow. That doesn't sound very good. You've asked a very good question though. And that is, and I think talking to you earlier, you said one thing you noticed moving between different hospitals, public, private, state to state, there's no standardization in how we approach and how an institution manages violence. And I think there's co-evolution by the sounds of things from what you said, but there's no standardization. Quickly, Kylie, that question, why is it possible that the states could organise and we could have some sort of movement towards a nationalised database for that?
Absolutely possible. And Georgina is leading that work. It's a recommendation. We presented it to Minister Hunt.
Oh, okay.
We need to work at a federal and a jurisdictional level, because it shouldn't be your postcode determines your safety. But the other thing that I'll just say just in support of Jackson's comments is, even if the reporting is inconsistent and it's a 10 or 50% variable of correct or incorrect, what we've experienced at the Australian College of Nursing is an overwhelming response from nurses anecdotally, or, as they're debriefing and sharing their experiences. And so right now, I think that nurses are under even more duress, as is the health system, but the frequency and the type of occupational violence has increased and is really becoming of alarming rates over the last few months. And what I would say is that as people are maybe have a higher anxiety or less control over their own ability around lockdown or other restrictions. I know that nurses that are caring for people in facilities where lockdown has occurred and they haven't been able to, visitors haven't come in to see people, nurses are just experiencing tremendous abuse. So what I'm seeing through the pandemic, I think, has escalated an underlying condition is when people don't cope, or we don't have that civility and that ability for people to learn how to express themselves in certain ways. It's just some sort of, I guess, unconscious or subconscious psychological right to then unload on somebody else. And so I think we do have a lot of work to do in how people respond or react.
Yep.
And those boundaries. And we have seen alarming rates, or we've heard about the stories, the incidences over the last few months and through the COVID experience has exacerbated this, which is very, very concerning. And I think what Jackson said, there's nurses who have left who won't return to the profession or to work because of their experiences.
Yep. I think another segue we've got here is because if we are going to report, then technology is going to make it a bit easier. It is already starting to do that. So David, if you can give us a bit of the one controllable thing from what I can tell, other than, you know, good policy and good education for nurses going in, one very controllable thing for an institution might be technology. And my sense is, not having done really deep research, is it's pretty random what level of technology around this problem an institution might have in Australia. But having said that, it's pretty random what technology between hospitals have anyway. Can you give us a rundown, David, of what you think the key technologies are and where they're being implemented? And then, you know, if this, because I know I've been talking to you, is there problems even when they're implemented well in terms of people keeping them maintained and stuff like that? And I'm not just talking about nurse alarms and the platforms for that, but, you know, systems which will feed off those platforms that get data that are HR systems that might talk back to an institution and identify problems.
Thanks, Jeremy. Technology very definitely has a role to play here, and it's across a diverse group of areas that need to interrelate and integrate, and really it starts at the basics. You've got to be able to, when you're talking about personal safety systems, which is the prime technology area, you've got to be able to firstly institute appropriate technology for the context and for the setting, and that'll differ facility to facility based on the type of work done, the physical characteristics of the facility, whether work is all done on campus or whether there are members of the caring cohort who travel off campus as well as on campus. So you really need a technology platform that's designed around all of those contextual elements. And that means each client, each potential opportunity where this technology will be employed may well need to be different. So you don't necessarily have a simple standard, this is a one-size-fits-all technology platform. Additional to that, though, you've got to stop and look at any system for providing employee safety is really only as good as the response from the institution. And that response has to be broader than merely we send help when an event happens. It's how do we trap the data? How do we analyze the data? How do we use the data to inform better policy, better design, better training, all of those elements? And then how do we consolidate the data into bigger data sets at a state level, at a federal level, at a local health district level, so on and so forth? We've got to blend all of those elements. In the marketplace at the moment, one of the key areas of focus is certainly in the overall work health and safety environment, and there's a lot of pretty smart technology being put in place, driven out of HR databases and HR systems. But one of the things that we hear anecdotally is they're not necessarily easy to get the data formatted into those systems from that point of an event. And that's, I think, still a gap. If it's hard to collect and collate the data, that's always going to be a practical barrier that everybody needs to try and figure out how to overcome. So again, take a step back and start from the basics. Have a system that provides protection, appropriate contextual protection for your staff. But a key component is you've got to be able to log the data. And that's for the immediate events, but it's also for those trend analyses. If, for example's sake, in a given location, there are a known number of events that happen in the same location, then we should be able to drill into that data and understand why are they happening in that location. Is there a set time or a range of times that duress events are more likely to occur there? What does that look like when contrasted against, say, rostering levels?
Yep.
Is it only when there is fewest staff that these events happen? That has HR implications for us. But if it's also strictly in a zone or an area of the facility, is there something unique about that area in the facility that makes it harder to provide practical safety to staff?
Yeah.
Those are the things that need to be trapped. We also need to trap how institutions respond. Do we broadcast safety events to a wide range of people? If we do, how many of those people that are broadcast to actually respond to the event? How many of them reject that call to assist because of other matters? And again, that could be related to HR issues. It could be related to simple technology issues that in certain areas, the signal isn't being transmitted rapidly enough or consistently enough. There could be technology underliers as well. All of those factors need to be considered when we design these systems.
So it sounds like there is a lot of good technology that can get a lot of good data, and you might be able to make a heat map and you can drill in on hotspots. But I have a sense, and I'm not sure you should try and answer this, David, but having done some work on nurse call systems as a base, it doesn't feel to me like these sorts of data platforms will be very widespread or standardized throughout Australia.
That's a fair point. Yeah. And I think, again, it comes to a policy level. And if you contrast, say, 3 states, if you look at Victoria, New South Wales and Queensland as 3 states, and look at the policy basis around staff safety systems in the health context, they're all quite different. New South Wales is very prescriptive. It has an extremely detailed policy on protecting people and property. Victoria, a little less prescriptive. Queensland a little less prescriptive again. So we have those state-to-state variations that make standardisation a little bit difficult. We have some overlays in other areas. We have things like the Australian standards. I think it's, from memory, I think it's 4485 is the relevant standard for security in healthcare facilities. And that, I'm pretty certain, covers duress alarms specifically, but also a range of other technologies. We also have the model codes of practice from Safe Work Australia that talk about managing the work environment, and that talks about safety for employees as a key part of safe work, safety for employees in particular situations, such as remote or isolated situations. But again, no one piece gives absolute clarity or consistency right across the environment. And that, I think, adds to the complexity.
So if I put a bit of a loop back on this to the social situation around what seems to be happening, I mean, there's no hospital in Australia that isn't, no significant public hospital that doesn't look at some sort of sophisticated new EMR solution as a base. And I'm going to put this question to you, Georgina. If my understanding of, say, and I'm not trying to push ASCM here, I promise, but or tech, but I look at it, my understanding of something like of nurse call systems, having done a bit of research, is they're very basic, mostly across Australia, especially compared to America and Europe. But this seems to be a problem that should be far more seriously dealt with at a policy level, with technology, maybe, with the right context around how you guys see it and organise it. And one thing I found when I was looking into digital health integration in hospitals is nurses are the coalface, and nurses actually do the most, and nurses are in a position to save the most amount of lives and save the most amount of money. But in the specification process for hospitals, nurses are very downgraded. They're there now. You'll see some digital nursing officers in a program that's upgrading a hospital or a new hospital. But overall, it's still a pretty older process, a little bit male oriented, a little bit consulting oriented. So I'll get to the question, Georgina, is do you think with these evolving technologies, there might be a bit more pressure put on policymakers to say, hey, there is actually a potential, there is potentially something concrete we can do here in terms of affecting technology that will get data and standards that could help us. I know it's a very complicated path, I know.
Yeah, look, thanks for that, Jeremy. I think certainly the policy is important, but I think we're missing a piece in that you have to get the nurses to have the buy-in if you change. And there has to be co-design, and there has to be some sort of empowerment of nurses to tell you what works and what doesn't work. And at the end of the day, you know, we will focus on the patients. And if the technology is going to interfere with our patient care, we're not going to engage in that. So, I mean, I think, David, you identified that sometimes it's not easy, it's complex. And this is the key, you know, unless you get the stakeholder, which is the nurse, to engage in this process, to do the co-design. I mean, we've seen EMRs and how they fail. As nurses, we want the EMR, but you have to enable us. You can't increase our workload to make us safer. It's got to be, there has to be a link here. It's not that nurses don't understand technology. It's that when we are probably the only profession where, or, you know, healthcare in general, where technology actually increases our workload. And so that has to be considered somewhere down the track. That has to be recognised that if you want this, and we're really, and as nurses, we want to be safe. We want that technology. We can easily engage in that. We've been engaging in technology since technology existed. So, you know, but there has to be an understanding that the policy can be developed, but we won't implement the policy if it's going to continue to increase our workload. You know, the reality is patients are sicker than they were when I started some decades ago. And so, you know, that has to be considered. That's the secret to me. It's that sort of supply chain, whole co-design it with nurses, ask nurses what the answer is. They'll give you the answer. It's pretty simple. And it is complex. It is complex if you want that technology. But again, it also has to be acknowledged that the complexity of the contexts in which nurses work is so varied. So rural and remote, and the distances. You know, I was in a meeting this morning where they were identifying in remote areas that if police are under duress or have a traumatic situation, psychologists are flown in. But if the nurse has that, nobody does anything about that. So, I mean, that does not seem to be a reasonable situation. And whether it's a male-female thing, it's historically been female. Historically, our image has not been necessarily, you know, portrayed as a good image. I mean, Kylie was talking about how we do that sort of body work. We do that work that our people seem to think we were born to be nurses. I can tell you I was not born to be a nurse. I worked really hard and I've studied for many years. And I think this is where the whole image of nursing needs to be lifted. And I think also, Jackson, what you said about, you know, you can't see violence ever ending, that's not a reason for us as leaders not to continue to work on that, not to continue to look at improving the technology, improving the policy, improving the culture, and making things psychologically safe. If it's a psychologically safe environment where nurses are enabled, you are definitely going to get them to report the data if the technology is there to report the data appropriately. But, you know, it's culture, it is a social issue. And if you ask nurses, we probably have the answers to most of those things. And I'm not talking about me personally, I'm talking about the nurses at the cold face like Jackson. They can give you those solutions. They just need to be enabled. So I don't.
Yeah. But I think I get what I think I do get what you're saying. And between Kylie and David, maybe the idea that nurses aren't involved enough in co-design and in the process, but also there just seems to be like sometimes you can put in tech, like actually EMRs are a good example. We put EMRs in and they killed everyone. They doubled doctors' time and ruined efficiency. So to your point, Georgina, you've got to be extremely careful about it. I just look at the idea that you've got to, attacking the problem is going to need some data. And I also get the idea that, you know, you don't want to be bogged down like clinicians and nurses have been bogged down by EMRs. Maybe, David, you could have a quick chat to that point, and then I'll go to you, Jackson, to get a coalface shot at it.
Yeah, thanks, Jeremy. Georgina makes some great points, really, really valid points. Getting buy-in from the people who are going to use these systems and being guided by the practicality of the systems in use is absolutely central. And yet, too many times, and I'm talking here as a vendor, too many times we get involved come into environments and are asked, what can we do to build a duress alarm system to work on this platform? And you do some discovery with the clients and you work through the process, and it fairly quickly becomes clear that the caregivers, the nursing staff in particular, have a decked phone clipped to their belt. They have 3 different pass cards because there's no continuity of swipe card access to various parts of the hospital. They also have all of these other bits and pieces clipped to them, and suddenly they're walking around with a fireman's belt. The only thing they're missing is the axe. Why are we not looking to leverage the technology that's already there? If you've got a decked phone, you know what? We can put a really good, accurate duress system in that leverages the decked infrastructure. If everything in the environment is run off Wi-Fi, we can go down that path as well.
But
If
David,
the users, sorry, go on.
I'm sorry, I'm interrupting, but you're just making a really good point. There's technology that pre-exists that it doesn't seem people understand.
Correct.
Or know how to implement. I know you're the vendor and you're like, oh, geez, why can't they just do this? But why is that happening?
I think because, and for justifiable reasons, people are guided by what they are aware of and what they come across. And there is a belief for duress systems that predominates in the industry at the moment that a duress system must be a Wi-Fi linked RTLS driven system. It's not necessarily true. There are multiple different technologies out there, not only technologies we provide, but many other vendors in the space provide. There are technologies that use radio signal strength, that use DECT, that use ultrasound. These are all fundamentally viable technologies that will deliver the outcome. I think what we've got to do is take it back to a focus on the outcome. What is it we're trying to achieve? Start from that point and move backwards, rather than have a biased perspective that we begin with. Wi-Fi is the perfect example. We know that Wi-Fi in health is ubiquitous. It's in every hospital, and it's spread and diversified enormously. But what we've overlooked is the load that goes onto a Wi-Fi network, and the reality that the Wi-Fi network is not a static set and forget service. It evolves, it changes, it has things done to it, intentional and unintentional. We know of horror stories where building works have been undertaken at hospitals and the Wi-Fi network hasn't been considered for the impact that's happening around the building works, only to find that electrical contractors and others have come in and physically disconnected Wi-Fi access points. So from perfectly good duress alarm coverage and voice coverage and data coverage, you now have these glaring black holes where nobody is safe.
Yep.
Because the Wi-Fi has been changed. That's the reality that happens, and we're not thinking about that from an outcome point of view. We're just saying, well, Wi-Fi is the technology we'll use because it's there and it's safe and it's robust.
When I talk to you, David, I'm like, wow, there's a lot of existing technology, even in basic systems, that we're not optimizing. Jackson, why do you reckon that is? I mean, because I look at it and I go, well, you know, there's a whole spectrum and there's a whole cascade up to the top of a policymaker. There's the designers of the hospitals, and I'm pretty sure at the design level it goes wrong at the moment because it's still an old world. But if there is that there, and if there is this need, do you think there's a possibility that from the coalface you could get people trying to make change?
So yeah, I wanted to jump in a few times. I've just written down a few dot points that I might just counter or give a different perspective. Wi-Fi in every hospital, I would say Wi-Fi is not in every hospital, especially if you're looking at rural and remote areas. They do not have access to even phones to communicate with police. So an issue to deal with.
Yes.
Data, I'll go to EMR. So I know we're doing a lot of bashing of EMR, but I would argue that personally, having used it, far prefer EMR than having to read doctors' handwriting. It is far safer. It is far more efficient. It allows data to be tracked and alerts to be notified when you have risky patients. Yep. So EMR is definitely, when done correctly, the right way to go. And there's good hospitals in Victoria that I've worked in that use it. I've used ASCOM phones before, and I wouldn't necessarily, I would feel unsafe working in the hospital that doesn't use them. I'm not here to advertise ASCOM, but having used, we in emergency where I used to work would always carry an ASCOM phone on us if we had enough. And obviously we didn't have enough, and that was a big sort of a friction point, is that there wasn't enough ASCOM phones, but they would pinpoint where you are. But the issue with this, and not necessarily where I work, is you can press the duress alarm, but maybe no one will respond. And that now is another issue of staffing. So when you talk about private hospitals, if private hospitals are your client base, a lot of them don't even hire security. Like there's literally no security in major private hospitals in Melbourne. I've worked at them. As an orderly, the orderlies, like the porters, the push people in, would actually respond to aggressions of violence along with a random nurse from another part of the hospital. Like there's so many elements to make the whole thing work to actually be safer. So we can have all these, but then you need people to respond to them. You could have someone psychotic going crazy at you, and you obviously need a duress button because you can't call for help, but then you need someone to actually come and help. So I think ASCOM phones are great. I think that's, I feel unsafe knowing the hospital I'm about to work in doesn't use them. In regards to data and the documentation that we're talking about, collecting data, as Professor Georgina said, there is literally no time left in an 8-hour shift and 12-hour shifts to spend more time documenting. Currently, in Victoria anyway, I use Riskman. So Riskman is what we use to document data. So that requires the act of aggression or act of violence to occur, then requires that person or those people to somehow find time while not caring for someone, which is not really possible, to then document for about 10, 15 minutes, up to 10, 15 minutes about what happened.
Wow, that's a lot of time to take.
That's what currently happens. And there are people I know who are doing things to reduce that time, and there are systems in place and other health services that are much shorter than that. But it requires people every time they deal with an act of aggression or they feel unsafe to document it, and it doesn't happen. That's why I bet you if everyone did that, that's a bit even worse. Yeah. So I guess you need buy-in from nurses, as mentioned. Like you can come up with these things, and I think they are so powerful. And like, yes, we may not be able to stop all violence, but we need to create a culture and a structure and a system that wants to, better it. But then you need the people at the cold front, the clients, the people at the stakeholders, the primary stakeholders, nurses. So in your project management spectrum of creating this whole thing, you need to put the stakeholder at the center, which I'm sure people do. But time, documentation, and access to security and Wi-Fi, staffing levels, ratios, skilled staff. There's so many issues that needs to be coupled with. So in my opinion, when the health service, when you go to implement a technology, you need to make sure that the rest of the framework is there. Otherwise, it will not work, and it will all just be rhetoric, in my opinion.
Just on your opinion, I love that you're here, because we often do these higher level things, but we don't have the reality check person. Is the person, oh, you're actually doing this and you're actually experiencing it. It's very, very valuable, Jackson. Thanks. I found this really good, and I want to do another one as a result into the future. And I don't think we're anywhere near getting really deeply into it, but we have to finish. So if you can just gather your thoughts for a sec, each of you, and give me 2 minutes of what you think might be the most important takeaway for people who are listening to this in terms of moving forward on this problem, not necessarily just around technology, but the whole problem, and then maybe with the context of technology. Again, putting it on you, unfortunately, to start that process, Georgina.
It's okay, I'll try and be short because I've probably taken up more than my time. But I think, as I said at the beginning, I think it's multi-pronged. So it's a social issue that needs to be approached at a government, a policy, an organisation. Nurses need to take it on, which we have. Society needs to take it on. I mean, I think, but probably the last thing that I would just like to say is that we as a society, as a people, need to care for the carers. If we don't care for the carers, then the carers can't care for us. And in this situation, the carers are us as nurses. And I think it's really important that people understand that occupational violence is something that all nurses experience. and it's not acceptable, and that we have to continue to do that work to try and improve that. Technology is part of the answer, but it's only part of the answer.
That's good. Kylie.
We definitely, nurses know our business and what we do. We need to work with the best of the best to have tools and support. And I really welcome the opportunity to do that, because we everyone's an expert in what they do. Health is healthcare is a monster. It's a beast. It's a huge percentage of GPD of every country. It's a multi-billion-dollar business.
Yep.
And we don't have one health system in Australia. We've got many, and then pop-ups like we've seen with the vaccine clinic. So what we do is work in a very complex system, and we need simple solutions. I've seen a question from somebody who's anonymous. It's not a one-size-fits-all answer. I've read your question about rural and remote health and the challenges for nurses. This is one of the areas that we have been championing and will continue to, is it's not a one-size-fits-all. Yep. Depending on where your work environment is, I can see that things are being done in facilities, but again, Gail Woodford was a nurse who responded to a call on her own in the evening and was raped and murdered, mother of 3, 55-year-old, drove the vehicle, whether it's an ambulance or not, didn't have a second responder.
Yeah.
But we really need to do more for all of the situations people find themselves in. As a nurse, I could be handing over to give some, to help somebody or give them medication, and my arm gets grabbed. So what I want is for David and the experts to sit around and tell me, how do I prevent that? Or as Jackson said, when we're fitting 10, 12, 14 hours of care into 8 hours, I don't then have capacity to then write it up. Riskman has a near miss situation. Who's capturing that? So we need to be the absolute support for those that are in that interface. But most importantly, when I say zero tolerance, what employer is going to discharge somebody who hurts a nurse or a worker? And that's where it comes to, is if you value your care or your relative, don't abuse or assault staff, otherwise don't come to the service. And that's where I want governments to be brave. Yeah. And even those with cognitive impairment still choose the same nurse to either sexually harass or sexually assault, or to have the same episodes of violence. Yep. And so at the end of the day, what does zero tolerance mean? You don't get care if you don't treat us well. And who's going to be brave enough to do that? So I'm looking forward to a time when that is what it will take.
Okay, thanks. David.
Thanks, Jeremy. Some great comments from both Kylie and Georgina, and also some of the comments that Jackson made as well. And I take on board your comments, Jackson, about the ubiquity of Wi-Fi once you get into the rural and remote areas. It is absolutely true. And I guess my thinking at that point when I mentioned it was around major hospital institutions and the like in the larger cities. From a technology point of view, I think, again, I would stress, we've got to look at this as a totality of what we're trying to deliver rather than a unique technology, and be open to the fact that there are multiple ways of reaching that outcome. They've got to be contextually derived and delivered. They've got to factor in the requirements of the end users. That voice must be heard loudly right through the entire process. And when we look at a system, from our point of view as a vendor, we try and work off basically 6 pillars when we're looking at personal safety and alarm systems. And I'll start in, if you like, in reverse order. Reporting and logging has to be automated, and it has to be end to end. We have to capture every point of data automatically that we can capture, because we recognize people don't have the opportunity or the time or necessarily the capability to sit down and trap every single thing that happened in that event. So the system has to have the intelligence to do that and then produce the data in a usable format to inform decisions. That's critical. That's a starting point, and that's a first pillar. Secondly, there's got to be a pillar around familiarity, compliance of use, and ease of use. That reflects what the user requires. We've got to make it easy for them. We've got to be able to support testing. Can you test the device before you come on shift? Can you be guaranteed that before you walk out from handover, the handset or the device that you've got will actually raise an alarm reliably. That's a key thing in my mind that you've got to be able to do. You must have a mechanism to do that. You've got to also consider your coordinated emergency response as a pillar. What is it that you're going to do? To Jackson's point, if you don't have security in that facility, how do you respond to an alarm that's raised? And what is that response? What does it look like? You've got to have a way of coordinating that appropriately to the context of the event. Now, does that mean you also rely on technology? Do you embed things, and relatively simple things, managed messages through the platform? Do you invoke an open channel communication? Do you allow a listen-in mode to the event as people are going to wherever that event might be occurring? Because they'll all inform the response team as to the nature of the event. Another part of the if you will, another pillar is repeatable and appropriate location accuracy. It's no good having a system that calls the cavalry if the cavalry's going in the wrong direction. We've got to know where you are. It's got to be accurate. It's got to be practical to the environment. If you're working in an area that is multiple small rooms, you need room level accuracy. If you're working in an area where you have large open space, where line of sight is always available, then you don't need that same level of 3-metre accuracy potentially, but it's got to be contextually derived. The other pillar is there's got to be multiple alarm modes. You've got to be able to invoke an alarm quickly and easily, preferably one touch, one action, but also automated alarms, either man down, no movement, or person down. I'm not being gender specific. Person down, no movement alarms are critically important. Again, we have to be able to be sure that in every scenario, this system will work. If it can't work manually, it better work automatically.
Yep.
And then last but not least, is it fit for purpose? Does it actually do what you need it to do in that context? They're the pillars that we've got to build these systems on. And then we've got to take all of that data and bring it to reality commercially and not be driven by a simple commercial context.
Sure. Thank you, David. Jackson.
Yeah, thank you. If I was going to say some final key points to any decision makers out there, I've written down my list and I've just written them down now. Put nurses at the center of your decision making. If you are in a position to advocate for change, doesn't matter who you are, advocate for change by listening to this, by bringing awareness to the issue. So here's a plug, go watch the nurse break and the archived videos and be shocked by the verbal and physical reality that exists. You can find them on, sorry?
Good point. Go and watch them and be shocked. Yeah.
Be shocked, yeah. Because it's also slightly funny, the verbal abuse, sometimes you have to find humor in some of it. But it's also incredibly shocking that what some of the quotes are. Don't forget about the fringes, and they're not really the fringes, they're the majority, but don't forget about rural and remote aged care, mental health. It's not just the emergency department. And all the media and all the talk, and unfortunately my video, all the interviews were primarily with critical care, so ICU and ED. I plan to do something different in the future, but the point is that there's a whole world out there where there's more violence outside of the emergency department than in other healthcare areas. A good case study would be Monash Health. They use, as David was saying, like if I pressed the duress button, it would pinpoint exactly where I was. There was a listen-in aspect to it as well, so you could literally listen in to what they were being shouted at, or if the person had a weapon. So it was a very good system. And you could, if you were following someone who wasn't allowed to leave the hospital and you're chasing them around the hospital and you kept pressing the button, it would update where you were. You could almost be in the tea room and just watching like the journey of your colleagues like through the hospital. And that sounds humorous, but yeah, and like you do laugh about it, and I have as well, but it's incredibly useful because that person can turn around and start assaulting you, and they do have good response systems and security there. So advocate for change, make the framework, go watch the videos, and go check out ACN, because I think ACN is like, if there's a body in Australia that's trying to make change, I would say, I don't think the unions are doing a good enough job. I never hear from the unions. I don't even know who the leaders of the unions are.
Yep.
And I think there's issues with that. So I think the Australian College of Nursing is doing a job that is epic.
Okay. Thank you very much. Thank you to all of you. It's an issue I never, I mean, we try and pursue big issues in healthcare like this, and this is one of the biggest ones I've actually come across. It's probably because it's tangential to what we usually do, but it's huge. And you've all given really good insights into it. I think we're at the beginning, hopefully, of a journey here. And certainly we're going to come back to it. But thank you for all taking the time and for your insights. And we'll see you all next time. And oh, sorry, one more last thing. I apologize to the audience. The functionality on Q&A, I noticed, Kylie, you had a question. I don't have any questions. So whatever questions we haven't answered, I'll get to them. I'll get them from the moderator and get back to you and answer them in the article that follows this. Thank you, everyone. See you next time.
Thanks,
Thanks.
Jeremy. Bye.